Okay, so good afternoon, everyone. I'm Dr. Mitali, working as an assistant professor in Ahmedabad Physiotherapy College. Welcomes you all in behalf of Parul University. Today, once again, we all are here for a very informative session on F words of childhood onset disability. And for that, I would like to welcome our resource person, Dr. Surbala ma'am. Welcome, ma'am.
Thank you, ma'am.
She has done MPT in neurological and psychosomatic disorders. She is also pursuing PhD from Charusat University. She has more than 15 years of experience in this field, and recently she is working as an assistant professor in Ashok and Rita Patel Institute of Physiotherapy, Charusat. She is HOD of Pediatric Physiotherapy in SAME. She has contributed in research regarding pediatric disability and stroke rehabilitation also. So now I would request respected ma'am to start our today's session.
Thank you, ma'am, for the wonderful introduction. I will now be sharing
Ma'am.
my slide. Am I audible to everyone?
Yes, ma'am.
Okay. I'll put off my video before I share. Is it visible now, ma'am?
Yes, ma'am. It is visible.
Okay. Hello, everyone. The topic of today's webinar is on the F words of childhood disability. So when we say F words, it signifies the words, very important words in childhood development, in child development, which starts with F. We will come to know better about this in the coming slides. The outline of today's presentation would be about the introduction of ICF framework and the F words framework, and how these F words can be applied into clinical practice will be discussed. And we will also see an example by applying it through a case study. So the part one is about the introduction of ICF framework and the F words. So we are all aware about the World Health Organization's framework of the ICF. So it started with the International Classification of Impairments, Disability and Handicap, that is ICIDH, and it was formed in 1980. And this is a tool for the classification or for the consequences of diseases and their implications for the lives of an individual. So here, the sickness or a disease is referred to as the interference with the individual's ability to perform certain roles. So they consider it as an impairment. So according to this ICIDs, disease can lead to an abnormality in the physiological function, the psychological function, or anatomical structure, and that results in the disability. And disability, when we say disability, is a restriction in the ability to perform a particular activity which is considered normal for that certain group of people. And this disability can cause a handicap. So, and here, an handicap need not be always because of a disease or because of an impairment, disability. And handicap can be because the person has an impairment and leads to handicap. We often see they may not have a disability or a restriction. We have seen cases such as facial palsy or Bell's palsy. There, it is an impairment of an anatomical structure having some disfigurement, but does not have any restriction in any of his roles. However, the person is mostly handicapped, or they do not go out, or maybe because of shame, because of psychological impact on it. So it can lead to handicap without an obvious disability also. This framework, if we see, it is very negative in nature. It mentions about disease, it mentions about impairment, disability, it mentions about handicap, everything in a negative way. So, by much criticism and by not including the abilities of a person, this came out into a revision from 1993 onwards, and in 2001, the International Classification of Functioning Disability, and which popularly known as ICF now, has been formulated. So we particularly like this ICF framework. So if you see into this framework, the words which is used over here are quite neutral. It is body structure and function. It is not negative. It is indicating about structure and function. Next is on activity. So it is not limitation or something. It is the activity. Then participation, environmental factors, and personal factors. So here, this framework is quite neutral in its words. It is not negative, and it gives a positive vibe, what activities they are able to do and what participation they can do, and everything is connected to each other. Okay, body structure and function is connected to activity. The health condition may directly impact on the activity, or the health condition may also impact the participation without affecting the body structure and the activity. So everything is interconnected here. So it reminds on what to look for and what people can do, rather than looking at what people can't do in this ICF framework. So here, the focus is more on the strengths compared to the focus on the limitations in the earlier framework. And here it also focuses more on the can, what a person can do, rather than the person can't do. And it de-emphasizes on the traditional thinking of fixing and of normality or disability. So those focus has been de-emphasized. And the idea we need to promote here is about the development, about the child and the family strengths, say for example the achievements and how the family is doing, what are the personal factors which may improve, what are the other environmental factors which may be promoting the function of the child. So we have the better framework to look upon in all the areas which a person can be able to do. So the framework, that is your efforts framework, started with this article, which was written in 2011. And the great authors were Peter Rosenbaum and W. Gotter from McMaster University. And they initiated this concept of the F words, which is inspired by the framework, that is the ICF framework. So if we look into this efforts framework, it corresponds to each component in the ICF. For example, for body structure and function, the efforts corresponds to fitness. For activity, it corresponds to function in case of efforts. For participation, the participation of a child is his participation with his friends. So it corresponds to friends in the new efforts. Then the environmental factors for the child, the environmental factors is their family, and their personal factors, what they think of is about fun. Okay, what is fun, what is enjoyable, and all these efforts ultimately is leading to the future. So in this article which we have discussed about, that is including the efforts, which says about the function, family, fitness, fun, friends, and future, are all embedded into this framework, that is your ICF framework. And it provides an appealing way for people to incorporate these concepts. Okay, we have been traditionally focusing on mostly the body structure and function, such as the person has a deformity, it has a spasticity, it has muscle contracture, and they are unable to do this. And we oftenly neglect about what are the participation aspects of a child, what are the friend circle of a child, how the family has been helping it, how the family has been doing, and what are other personal factors which is helpful to come up with these problems and solve these problems. So that has been less focused in the initial or the traditional way of rehabilitation. So this gives us an opportunity to incorporate all these concepts into every aspects of clinical service as well as in research. And it is also easily understandable by the children and the families. It is not a complicated word such as an handicap or something, but it is easily understandable in the entire rehabilitation team, including the parents and the children. So this is about the F words. When we say functioning, it refers to what people do, how the things are being done, and actually it does not matter how it is being done. Mobility is one of the function. Okay, able to transport, able to go out of the home is one of the function, is one of the outcome. But it doesn't matter whether the child is using a wheelchair and going out, or whether the child is using a walker or not, or the child is walking independently. It all doesn't matter. The outcome is the ultimate matter. So that is what is functioning matters in case of an efforts. Then the family. Here the family represents the essential environment for the children and the youth. Okay, for the young children, it is only the family. They have their parents, they have their mom, they have their dads, they have their grandparents, and those particularly who live in a joint family, they have all other cousins who are playmates for the children. So the entire family represents a social environment for the child and the youth. Then next is the fitness. It refers to the physical and mental well-being. So for a child, when we consider about fitness, we will consider whether the appetite of the child is appropriate, whether the child is playing well, whether the child is sleeping well. So it is an indication of fitness in case of a child. Next component is fun. It includes the activities that people enjoy, that children enjoy. It may be just watching some TV, it may be playing the favorite video game, it may be playing the favorite toy. So that itself can be used if the child is having fun in those activities, that can be incorporated in the therapy to achieve more outcome, or that can itself be a goal itself. Then the next component is friends, and it refers to the friendship established with others. For a young children who is receiving a therapy, it may be a therapy mate which is there in the department, which becomes good friends. It may be the family members, cousins, they are good friends. The mother can be a friends. So who are the friends for the child who is motivating them in order to play? Okay, if we see any children uses they have to go out and play with friends, is so exciting for the children. Okay, so friends play an important component in the development of a child. And what all these represents is future. Okay, that is life is all about future only. So here it represents the strengths-based ICF themes that is grounded over these 2 decades. ICF themes has been there since 2001, and that it has been grounded by the ICF themes. And this 6 F words should be the focus for all the children's health and their development. And this is how the F-WORDS framework is represented in terms of how a child would consider. In case of body structure and function, that is fitness, everyone needs to stay fit and healthy, both physically and mentally. So physically and mentally, for a fitness of a child is required for them to play in the community, for them to play actively. So we have to find ways how to keep them healthy. A good appetite, a good sleep is an important function to improve the fitness in the children. And in the activity, the children with disability may do things differently. Okay, they may not be able to hold it with a hand, but they may use an adaptive spoon to gain the function or to have the outcome of a self-feeding activity. And they may use a wheelchair for the mobility, but how they do is not important. Okay, let them try whatever they can and achieve the outcome. Next is participation or friends. Having friends is important. We should give opportunities for the children to make friends outside of the home. It may be in the therapy, it may be in the rehabilitation center, or if the child is attending some Anganwadi center or school, the child should be given the opportunity to make friends with the others. And the family, mostly the family knows everything. Okay, especially here in India, we have mothers as a primary caregivers, and if we ask mothers, they know most of the things about their child. Okay, so when we see them, we have to listen to the family, what the mother is saying, what they are expecting. It has to be spoken to them, the conversation has to be quite open, hear them and respect them. And that family itself can become a good motivation for the children and their development. The personal factors, that is all about fun. And when we incorporate activities which are fun for the children, they find it more interesting to do that particular activity. And the future is, let them grow with all these opportunities. The future definitely will be bright for the children. This is about how the F words has been taken up in the research in various countries in various parts of the world. And in total, researchers from about 26 countries, this is a report from 2019 by Soper et al. Currently, around 26 countries from around the world have taken up this F words, at least cited in their research using F words. And this may continue to increase. This is a report taken from 2019. So currently it is 2022. We may expect that there has been more uptake of F words in research and in clinical practice. India belongs to the category of around one where we are not so poor. We have started taking up research on efforts among in our country itself. Next is the part two. The part two is about how this efforts can be applied in the clinical practice. So when we actually go into clinical practice, we have to apply how the family can be used for motivation, how the fun component is taken into consideration while planning the rehabilitation. We will see further how it is applied into clinical practice. So application of efforts, this is on Rosenbaum's views. Okay, he says that he always asks the parents, "What do you want to brag about your child? What is good about your child, or what is best in your child?" And he also asks about things that they are happy about. Then once we know the child is good, when we say what do you want to brag about your child, they may answer मेरे बच्चे अच्छे हैं, ये ऐसा उसको ये बहुत पसंद है, ऐसा करना आता है. So that those are some of the things, positive things which we may hear from a child. So we take into these positive ideas, we take into these positive components, and the can of the child, what the child can do about. Then he suggests the parents to how these things which they have talked about the child will fit into this ICF framework or the FOS framework, and uh, uh, is incorporated to bring these ideas into life. So this is how Peter Rosenbaum applies the F words in his clinical practice. He is a professor in McMaster University, and he has more than 50 years of experience. So when he says something, then I think it is worth believing. So that is how we have started applying efforts in our clinical practice. Okay. Here, I will give a brief introduction of how do we apply efforts in our clinical practice, the challenges we have faced while applying these efforts, and the suggestions on strategies to support the implementation, benefits of implementing the efforts. And we have applied these efforts during our clinical practice in the clinical education of our UG and PG students, and also even during their case presentations. So the now explanation which I'm going to give further is on our personal experiences of how this is applied in the clinical practice. So how we are using efforts in our clinical practice, we use this as a teaching tool for the students. Okay. And to encourage them to think about designing exercise interventions in the areas where the child or the parent feels the most important. So if they say that my child needs to do this, so we consider that as an important outcome for them because they want it, and we aim to achieve that goal. So it becomes a very good way, which is patient centered, which is family centered outcome, and it is goal oriented. So it also assists in goal setting and translating the outcomes into other aspects of the child's life. Okay, it is not always disability and deformities and problems, but it is about other aspects of the child's life, such as their family, their friends, their fun components. So we it helps in assisting our goal setting in those areas as well. And this efforts, when we apply, it is easily understood by everyone in the team, that is including the family. Aapko kya pasand hai? Okay, if you ask a child also, they will be able to easily say that I want to do this. What you want to play? What is your favorite game? When we ask this, the child are easily able to understand. So the assessment and the evaluation is quite easy among the families because the words are quite simple. And we found that the fun and the friends part in the child's life is something which were not looked for in most of the areas. That is the fun, what you like about, and what are your friends. Okay, we say how is the family, environmental factors, the family is supportive, we have been always saying that, but the fun and the friends are some area which has not been explored or looked for. So even when we ask about the friends to the parents, they are not aware, they don't have any friends, वो चल ही नहीं सकता तो इसका तो कोई friend नहीं है घर में जो हम खेलते हैं. This is what we have. So this is an area which has never been looked upon, and these efforts has given us the opportunity to explore those areas and bring that into their child's life. So the inclusion of these components is definitely helping us in exploring the ways to find out what is best for the child, because they are isolated. They tend to be isolated compared to other typically developing children. So we started looking for the child, and even the parents started looking the child as like any other normal individual, then someone who is a kid which can't do many of the things, or they are not walking. Rather than saying those, they started exploring other areas in their life as well. So this is how one of the case presentations done by the fourth semester, and how it has been applied. Okay, I have shown only the last slide when they have analyzed and put everything into the framework. When this is about a child who is around 1.5 year old and has a global developmental delay with a history of CTEV operated at around 2 months with the poinsettia technique. So in this child, here the words are written in a way how the child will express. Okay, so the words are being said by the parents, but it is expressed in a way how the child can express. The child can play, eat, and sleep well, but he is already 1.5 year old, so he needs to play more and explore more, walk in different areas, explore many other individuals. So it is how it is being put up in the framework. So each component we have considered about the fitness, about the function, what the child is able to do, and what is further to achieve. Who are the friends for the child, and what are the other friends in the surrounding and in the family member, who is the favorite, and who can be the motivating the child to do here. On fun, what is the fun about it, and what the child would like to do in the future. Okay. So those components had to be included in this framework. We face many challenges while using these F words, or particularly while explaining to the parents. And when they have poor knowledge about the condition, when they have poor knowledge about the prognosis of the condition, we had many difficulties. And especially if the person is illiterate, it is difficult to make them understand. Either they may not talk to it, because this is not a tradition. When we start conversing, when we start talking, when we start including them into the rehabilitation, which is not a usual practice in many of our traditional rehabilitation, they will just put the child, and then their expectation is to fix the child. So we have many challenges. One of the challenge is very difficult to make the parents understand, okay, on what are the efforts, what is fun for the child, because they have not thought about it, they have not explored these components. What who are the friends for this patient, what fitness is meant to him. So these areas, it is very difficult to make the parents understand, and we still struggle at times. Parents have often unrealistic goals due to poor knowledge and literacy regarding the child's condition. For a child with cerebral palsy who is at level 4 or level 5, they expect that I want my child to walk like a normal person. Which is an unrealistic goal. It is not possible for the child to have a normal walking pattern. So we have to make them understand, because they have unrealistic goal. Then now the task increases on explaining them how the child will achieve his functions, and how walking is not important. If the outcome is being fulfilled, the walking is not important. So now this is a different again explanation which is required for these parents, because they have poor knowledge and literacy regarding their child's conditions. And traditionally all the parents wants their child to be fixed or find a cure. Okay, they don't want things to be done differently. अगर सब एक ही लाइन में चल रहा है, मतलब वही लाइन में चलना है. So it is still a struggle for us to apply these efforts in the clinical practice. Now here are some strategies how these can be implemented. Rather than looking at what is abnormal, what are the problem areas in the child, it is better emphasizing what the child can do, what's fun for them, by listening to the parents talk in the first place, and then putting those ideas into the framework. So here the interest is looking at that is what is possible rather than what is not possible. Because most of our traditional approach to childhood disability has been identifying the problems. इसको ये deformity है, इसको ये postural abnormality है, उसका trunk balance बराबर है, बराबर नहीं है. So these problems are being focused more, and these concerns, worries comes to the parents as well, कि ये नहीं कर सकता, वो नहीं कर सकता. Rather than thinking on नहीं कर सकता, we should look for what is possible for that child. Okay, so that we need to change at the first place before applying these efforts, and it will be easy for us. Okay, so during the conversation with the parents, take it in a positive way, what the child can do rather than what isn't possible for the child. So this requires a constant talking and conversation with the family. Then putting up an F-word poster in the clinic is a very good way to start a conversation. So when you put it up in posters, when you put it up in pictures, it is quite good. And we set some examples of frameworks where the photographs of children are being put up on the department, on the clinic, by putting these framework. And then it is a way, see, for this child it is like this, for you it is different, for so it is easy for us to explain. So using F-word posters is a good way, very good way to start a conversation. And using the F-words templates as a guide to think about questions and put them into the framework can also be done in order to imply this. Okay, I will show you how is the template. And this totally makes sense because when you think of the posters, it is visually appealing as well. When you see the poster, it is visually, the parents can see it, and the child, the pictures which is animated pictures which is being used are quite positive in nature, and it is visually appealing. So it is a great way for the clinicians, for the parents to start applying it and then accept these as a way of therapy or way of the child's working towards the child's development as well. And I think that any individual clinician who are including these template or the framework in front of them will have questions to ask for and put more information into these areas, and then answer more questions clearly which is raised by any parent. Okay. So this is the F-word poster, which can be applied. It is easily downloadable from the Kensil website, and it is now available in many languages. Unfortunately, not in Gujarati, but it is available in Hindi. And the translation process is going on in Hindi, in Gujarati, I mean. So these efforts poster to put it up in the department will be quite helpful to begin a conversation with the family and explaining them how the function is being, how family is important for the child. So we can see in this family's picture, all are joined together when one child is on a wheelchair, and how the play is important for the children, how fitness is important, how his friends are important. Okay, so these gives a visually appealing and a positive way to start any kind of a conversation. And these are the templates to plan for goals, a goal sheet, what they want, what they can, and what they want to achieve, and the profile of a child, what they can do about, what is the best thing about their child in these aspects of the F words. So these are some of the tools, and I'm sure that any physiotherapist or a care provider who is thinking in these F words terms, by including all the, if they have not heard about F words also, but if they are taking into account their parents' concerns, if they are taking into account their family concerns about their friends, how the child is participating in the school, whether it is time to go for the school, how the school is, whether the school is supportive or not. So thinking all these aspects in terms of F words will definitely have a better outcome rather than thinking technically in terms of a therapeutic approach to fix the abnormalities. So some of the benefits to implying or implementing the efforts, parents find it very positive way to think about their child. Initially, they were thinking the child is can't do, or this is not possible, ye nahi ho raha hai, ye nahi chal raha hai, ye. But with this inclusion, the parents find it very positive to think about their child, their family, and their possibilities in their life. So example one have given here is about holding a pen or using a pen. This emphasize the function and the outcome rather than not doing it nicely. If the child is not holding with a proper grip, it is fine. If it is not holding normally like other children do, it is fine. But if the child is able to write using a pen in a modified way, then the function is being achieved, the outcome is being achieved. And one of the greatest example is W sitting, which is considered as one of the major problem among orthopedic surgeons, among physiotherapists, W sitting in children with cerebral palsy. But it is a different way of doing things. If they make to sit like a normal in the cross-legged sitting, the child loses balance quite often and falls back. But when they are in W sitting, the pelvis is being locked. They have a wider base of support. Their hands are free, and it optimizes their hand function and explore areas to explore more. So it is just a different way of doing things, not an abnormality. So when we look into this way, then by rather than avoiding the child to do explore activities with the upper limb, we make them sit on a prop sitting in the normal sitting position, which we consider it as our that is cross leg sitting, then the function is not being optimized. So if we look it into a way that it is a different way of doing things, then there are much more possibilities which we can achieve with such kind of a problem which we see in children, which is not actually a problem. Next is to apply this in a case study. So we will see here, I give an example of one of our case which comes in our department. And we will try to fit all these components of F words into each category of all the six categories. Okay, six, future is what is all about. So I will not be talking about future of the child. If all these areas of other five areas are being covered, that the future automatically will be more positive than what we think of. So this is a case. Her name is Anvi. She is a 4-year-old girl, and she has been diagnosed with spastic diplegic cerebral palsy, GMFCS level 3. She walks with physical assistance, can stay awake and alert during the day, and she experiences difficulties sitting independently, transition from one position to another, and playing with other children. As she is unable to do, she is not playing with other children. And she lives in a joint family with grandparents, likes to play with her cousins, and loves food. She attends regular PT close to her home, and the PTs are very supportive. Here I am bragging about myself. We are the PT here, and we are quite supportive. So this is our child. So we will try to fit these into each components of the F words. Okay. So just to remind, here is the F words framework, including with the ICF framework that includes fitness, function, friends, family, and fun. Future, I have not put it up over here, and some of those words has been color coded. Okay, so whenever I put it as a red, the red indicates things which we want to pay attention to, and there are some potential issues and problems in the child. So those components which is put in red are the ones which we have to pay attention for. The one which is written in gray indicates what is working and what is functional for the child. Okay, the functional ability. And the purple color indicates what we need to know, which is not a part of the story which is presented to us. So initially I just show you a story, and those includes certain areas which we have explored. So what else do we need to explore more is written in purple. So in the body structure and function, that is about fitness. Diagnosis is spastic diplegic cerebral palsy. It is a lifelong problem, GMFCS level 3. So we know the outcome of every GMFCS level 3 child. They may be able to walk with a handheld device indoors. However, for outdoor walking, the child will be requiring a manual wheelchair. For long distance, the child may be using a motorized wheelchair. So this is the outcome of a spastic diplegic cerebral palsy, GMFCS level 3. So the problem is a lifelong problem. So the rehabilitation needs to be extended, and the child is able to walk now with assistance, but she is out of breath after walking for a distance of around 20 meters. After 20 meters, she is tired and she cannot continue further. Okay, she walks with a rollator currently, but around 20 meters, now she needs to take rest after 20 meters. So that is a concern. So if she has to walk outdoors or continue her physical activity at home, then this requires an extended period of time. So currently, this is the concern which we have in her. Next is on the abilities of the child. She walks with a rollator and with physical assistance. So currently she is able to walk. Very soon she should be able to walk independently indoors by using the rollator. So this is her ability. So now we will see what we have not explored further. Are there any biomedical issues? Such as if she's out of breath for walking for 20 meters, now I need to look for whether the child is having any comorbidity of a congenital heart disease or any other problem. So these are some of the questions which was not a part of, but we need to look for it. And are there any strengths? Yeah. The child is able to walk, but are there any strengths? Are the family, how is the family, how is the cousin, how are they playing, are they including them, are they making them take part in certain activities? These are some of the strengths which we need to look for. So by including these strengths and their abilities, we can work on the problem areas to have a better outcome. Next is the activity or the function of the child. So the child currently needs help with the activities of daily living, transfer, okay, because she has difficulties with transition. So that is a point of concern now. She is 4 years old, and transfer at this point of time, she should be able to get up from lying position to sitting position, and from a sitting position to stand up. That will help her mobile by using a rollator. If the rollator is kept around the bed, she can get up from there and then walk forward and explore things in the indoors. Okay. So now the transfer is one of the problem areas. She is unable to self transfer. So this is an area which we need to focus about. Next is she has good upper limb function and a sound cognitive function. Okay, so when she has good upper limb function, if she has to use a handheld device, it is quite possible. If she has to use a manual wheelchair, it is quite possible. And the sound cognitive function, as she has a very sound cognitive function, now she can even explore areas and join a normal stream school if she is able to if the mobility is being achieved. She also can achieve. Okay. She has other problems in the function, such as difficulty in speech communicating problems. We will see that I have kept it in the friends, but that is also one of the function which she has not achieved. She can understand. Okay. Then she can do floor mobility by creeping. So this are some of the functions which she is able to currently perform. And which areas we have not explored about are other areas which are being challenged. Okay, whether the vision is appropriate, whether yeah, hearing is definitely appropriate, but we have not looked for her visual capacity. So whether the vision is appropriate, what is her IQ, these are certain areas. Okay, she has a sound cognitive function is appropriate. She is around 4 years, and but what is the IQ level? Will she be able to go to a normal school? So those are some of the other areas which we have not explored for. Okay. And in the friends, she has difficulty in communicating with other children, as her speech is not properly developed. Okay. So except the mother, nobody understands what she is trying to mean. So she has difficulty. That may be a problem area when she has to make friends with other children. And she plays, shares toys and food with the therapy mates. She loves food, she loves toys and playing, so she does with the therapy mates. So she is quite social. So this is one positive aspect where she will be easily able to make friends when she go out. And here we should explore what a 4 year old is expected to do. Okay, so we cannot expect a 4 year old to become an adult. So what is expected out of 4 year old, so that we have to consider and work on those areas to achieve it. And does she have any social skills or strengths? Okay, so those we have to see. Okay, here she has been coming to our therapy. She seems to be quite social and attentive to or response to the commands, but we don't know actually, because she has been seeing us for the past 3 years and she is well aware of us. She interacts well, but we are not aware of what are the social skills. If she go out in the community, attend some social function, how does she behave there, which is scared or not? So those areas have not been explored for, so we need to explore those aspects as well. The environment here, the family. Here, the mother is the primary caregiver. We have never seen Anvi with any other family members despite living in a joint family. Okay, she has been coming in our center for the last 3 years, and we have never seen her coming with any other family member. Okay, she keeps on telling that in that the mother says that इनके इसके साथ ये हुआ वो हुआ इसके साथ ऐसा खेला ये कल इसको बता रहे थे, but still we have never seen Anvi with any of the family members, and that needs to be explored. It's a point of concern. Okay, if the mother something happens to the mother, or if the mother is not well, then her session will be stopped. Okay, because she is unable to bring her. So if any other family members are also available, then her therapy sessions will be continued and her participation to various activities will be inclusive. So that is an area of concern which we need to focus for. Okay, so that is something which but in our traditional or in our cultural setting, we have mothers as the primary caregivers, and the mother is the one who is responsible for everything. Okay, given they will blame the mother for the child's condition as well. So this has been a part of life, so it is not very easy. When we see this as a problem area, it is not very easy to solve a problem. However, our aim should be solving that problem. And here the positive aspects is a very caring mother, and she attends physiotherapy sessions daily, and we have a very supportive staff in our center. And the other areas which we have next not explored are what are the family's needs and supports. Okay, the mother has been coming here daily, but whether she require any transportation facilities, how she has been doing it. So some areas which we are not well aware of. Okay, they are not telling us the problem. However, they may have some issues. They may have some needs regarding the child's condition. So how the family, other family members understand Anvi, and what is known about the father or the grandfathers, that has not been explored in Anvi's case. So this is about the environmental or the family. Next is about the personal factors. She is just 4 years old, so I have not included any red points over here because I don't find anything is a problem area on the personal factors, on the fun factor of the child. Everything is so exciting for a child. So here I have not included the red area. Everything is good. Okay, she is excited to see new people. She is excited to find a chocolate. She is excited when we give a biscuit, a piece of biscuit. So it is all positive in way. So she loves food, anything. Okay, if we have to give an exercise, we lure her with the help of a food. After this, you will get one chocolate, and she is so excited to do that. Okay, she likes YouTube videos, especially ice cream videos, because she likes food, and she also likes playing with her cousins, okay, and other therapy playmates. And what we have not explored is what else is fun for it, because that has been a routine. Okay, we have been seeing this as a routine since the last 3 years. We have been seeing here, and we know only these components what is fun. So we have not explored what else is fun for these children. As the age grows, as she grow older, she will have different areas. She may not like the YouTube videos, the rhymes, ice cream videos anymore when she grow older. Okay, so what else is fun for the child, that we have to explore at every point of time. What is fun for the family is also an important aspect. The family is a very important component in her life. So what is fun for the family also should be explored, and which we have not explored. Okay, and how can these ideas be put into therapies to support the child as well as the family's development? Okay, so when we talk about family centered care, it's not only about the child, but it is about the whole family, a holistic picture to the child's life. So this is an overview of the story which we have heard about the fitness of the child, about the activities. So this is at the end how the framework is been. So I have identified color coded here the problem areas, the strengths, and the unexplored areas. Okay. So the color codes has been given here. The red is the problem areas which we need to focus on. The abilities, that is the child is able to perform. The strengths are indicated in green, and the purple ones are the ones where we have not yet explored and need to do further. So this is a framework, and with these framework, if we know what are the problem areas, we exactly know where to focus. Okay, where to focus. So the child has difficulty in communicating with other children. So it is time for us to refer to a speech therapist, to include speech therapy in her regular, or teach sign language if the therapy is not possible. The universal sign language, the cognitive function is quite simple. So we can teach universal sign language or include some speech therapy as per the need of the child. So the take-home message for this efforts is it allows a picture to see the child in a holistic way. Okay. So the ICF or the efforts allows us to gain a holistic picture of the child as well as their family. And it helps us to identify issues to focus on, the strengths of the child and the family, and the questions that are still need to be answered. So using this ICF words, it supports a family-centered, strength-based approach. So here it is not a limitation, a problem-based approach. It is a strength-based approach, and helps ensure that we don't miss any important information of the child in all the aspects of the child's development. Next is part four. It will be a quiz, but now I came to know that this is a webinar mode, so there are only few participants. But I'll just read out. This will just help you remind what we have learned about. So yeah, the first question is: I can do things differently. How I do it does not matter. Let me try. It applies to which of the F word? Is it fun? Is it function? Is it family? Is it friends? We had discussed this in the first F words explanation. And here it applies to how the things are being, the outcome is important, but how it is done, it is not important. Whether the child is able to go outdoor is the outcome. Yes, the child is able to go outdoor, but how the child is able to go outdoor, is she using a wheelchair, is she using a rollator, is she using a walker, is she using a handheld device, that does not matter. So it is the outcome, the functional outcome. So this F word corresponds to the function. The second one is on the environmental factors of ICF, that corresponds to which of the F words? Environmental factors. What is the most important environment of a child? The most important environment of a child. Currently, they do not go out. They have not yet started participating in the school. So the environment is the family environment here. Okay, the family environment is the most important environment of a child's development. Next is on which of the following is a challenge in the clinical application of efforts in the Indian clinical setting. So that we have discussed, and then still we say that there are so many challenges, and we still struggle to this point in explaining this framework to the parents, including them, and explaining them that it is not us to fix their child. They have a different life. It's very difficult for us to explain. So here parents want their child to be fixed is a common problem. Okay, so this is one of the challenges, and parents and families may have unrealistic goals, as I have explained, because they have poor knowledge about the condition, about the prognosis of their child. And PT struggle to make families understand the concept of efforts. So here the right answer is all of the above. Okay, all of these problems are challenges which we still face today. Quiz number 4 is what can we do to increase the uptake of efforts in the clinical practice? And there can be more than one answer. Okay, make it compulsory in the clinical education? I don't think so. When we say anything is compulsory, then the students definitely do not want to do it. So, making it compulsory in clinical education is of no use. Rather, you should think critically and how these can apply, which is more helpful and which is not helpful, what applies the best for the child. Sometimes it may not work for some children or some parents, or they want something different, okay, or the problem may be different, that it may not work. Okay, so looking for what is best for the child is important. So making it compulsory in clinical education definitely is not a way to increase the uptake. An F-word poster can be a good start of conversation, definitely. It is quite appealing, it is positive, and it is easy for us to explain to the parents. So using an F-word poster in the department, in the clinic, is a good start for conversation. Then using the F-word tools to set the goals and plans, the strategies, is also a good way. Ultimately, at the end, when we show these are the possibilities, these are the problems, and these are the areas which we need to work on further. So when we present in this way, it is very easy for us to make the parents understand, and they see it in a larger picture, okay, where we have included every components of their life. Okay, and so the answer is that the second one and the third one. Okay, and did not do anything. This is definitely wrong. We need to do something to have the best outcome for every child. Quiz number 5 is fill in the blanks. It helps us to identify issues to focus, and I want the answer which is green. These are focus on the strengths of the family and the child, and the questions that are still to be answered. Okay. So this green components indicates the abilities of the child, the strengths of the child and the family. Okay. So this is where we need to focus on the strengths, and then see what are the problem areas, whether these problem areas can be solved. If it is solved, then how it may become a strength for the child. Okay, so those areas has to be explored. So this is about the quiz, and for more information you can visit the Ken Child website, and these presentation what I have included, this I have not made up on. They have a very good knowledge translation hub in the Ken Child, where we can use their posters, goal sheets, and everything freely, and apply it in a clinical practice. If you need support on the explanations about this, they will also help us. Okay, so for more information, we can visit the Can Child website. And these are some of the glimpses of pediatric physiotherapy at ARIP. We include the parents and the children, their family members are very important parts of our physiotherapy team, and our students who work in cohesion with what is our concept, and it is fun filled. Everything is a celebration. Every day is a celebration at Department of Pediatric Physiotherapy. So with this, this is the end of my presentation. I, in the future, also stay connected with me. The website, then the Instagram, the address, everything has been given here. All the information has been given here. So that is about my presentation. Thank you, one and all.
Thank you so much, ma'am, for sharing your precious knowledge to us. I'm sure all students gain more and more knowledge of pediatric physiotherapy assessment and rehabilitation. And at last, I would like to thank all of you for being a part of this wonderful session. Thank you
Thank
so
you so
much.
much for giving me this opportunity. I hope I have made justice to the topic which has been presented, and it is helpful for the students, whoever is listening. Thank you so much for the
Yes,
opportunity.
ma'am. Thank you. Thank you.